We are pleased to welcome Dr. Roger Figueroa. He is the director and founder of the Figueroa Interdisciplinary Group Lab and assistant professor of social and behavioral science in nutrition in the Division of Nutritional Sciences at Cornell Human Ecology. The FIG Lab designs testable conceptual frameworks, measures, and multifaceted research studies to understand how policy, systems, and environmental factors influence diet and health-related outcomes. Dr. Figueroa is a transdisciplinary scientist with expertise in public health, nutrition, implementation, participatory, and team science. Currently, Figueroa's research examines the role of social services and policies such as childcare and food assistance, as well as sustainable food systems in the prevention of diet-related chronic illness, chronic diseases in low-income and minoritized communities. Figueroa has received training and research funding support from the USDA, NIH, and other institutional level grant programs. Please give a warm welcome to Dr. Roger Figueroa.
Thank you all for having me. So today, what we're going to do is to talk broadly about food and nutrition to support prevention and management of diet-related chronic diseases, particularly through Foodist medicine, through a Foodist medicine lens. We are also going to discuss the need to think about implementation science as a key approach and principles to advance health equity in ongoing and future Foodist medicine work. The first thing I want to do is to acknowledge, well, first of all, I want to say that this talk draws from a recent manuscript that me and my colleague, Dr. Bailey Hart-Tailing, wrote together last year. It's currently under review. It was revised and resubmitted over the winter break. And I want to take a time to acknowledge my co-author. So Dr. Bailey Hart-Tailing is from the Gretchen Swanson Center for Nutrition, and she's also a faculty in the Department of Human Nutrition, Foods and Exercise at Virginia Tech, as well as an affiliation with the School of Nutrition and Food Sciences and the LSU Agricultural Center in Louisiana State University. I think she also has an extension appointment, which is really cool because I love extension. So I want to acknowledge her as I use the manuscript as a basis to present this talk. So let's talk about diet-related chronic diseases. Diet-related chronic diseases such as type 2 diabetes, cardiovascular disease, and cancer are among leading causes of death in the United States. We know that over 60% of US adults are estimated to be diagnosed with one or more diet-related chronic conditions. And further, populations that have been historically marginalized and those with low income, sorry, feedback, are disproportionately affected by these conditions due to inequities in access and affordability of nutritious foods in part. What's that? Hello? Is that okay? Okay. Sorry, everyone. Poor diet quality is one of the main risk factors associated with these conditions. And we have nutrition epidemiologic, interventional, and meta-analytic evidence to substantiate these claims. And poor diet quality could be defined based on the dietary guidelines of Americans as dietary patterns that include higher amounts of ultra-processed foods, foods that typically contain higher amounts of saturated fat, added sugars, sodium, lower amounts of fruits, vegetables, whole grains, for example. And although there have been many efforts and variations to promote diet quality and prevent these chronic conditions, it is most recent that researchers have bought into thinking about nutrition security as a national and global priority for preventative medicine and the management of disease. Nutrition security is defined by the USDA as a consistent and equitable access to healthy, safe, affordable foods essential to optimal health and well-being. So let's put nutrition security in perspective. I'm going to draw on Darius Mozaffarian's published work as a departure point for our discussion on nutrition security. Indeed, nutrition security must be a priority for many stakeholders across multiple sectors, including healthcare systems, government programs, community agencies, and others. One way to depict nutrition security is as seen in this figure. The argument is that the lens offers a complementary concept to addressing hunger, food insecurity, and nutrition insecurity all at once. The problem, which you see at the bottom of the figure, ranges from most immediately hunger to food security and diet quality concurrently, as conceptualized as nutrition security for short. And the solutions, which are in the, above in the figure, range from access to any food all the way to consistent access to nutritious food, stability of nutritious food availability, and ultimately use and consumption of these foods. Through this lens, we can think of food as medicine as a cascade or pyramid of programs and interventions based on specific populations' needs to promote nutrition security, ranging from prevention all the way to management. I would also say, and I think this is in some ways, I'll say an opinion, but when we think about food as medicine, I like for us to think about it as a framework in which we organize a number of different interventions that can help the population have greater access to nutritious foods. So I'm going to provide an overview of these. At the baseline level, we have population level healthy food policies and programs. Broadly, these initiatives aim to influence community, socioeconomic circumstances, and larger living and work environments of people, work sites, schools, early childcare, prisons, and others. Other examples of these policies could be food taxes, incentives, as well as food labeling. Another relevant argument to all levels, I'm going to use this section to say this, is that at the individual level, nearly all interventions have a core foundation of increasing affordability, whether through vouchers, discounts, incentives, or direct provision of nutritious foods. So here's an example of a population-level healthy food policy or program. Match programs broadly, but more specifically in our state, we have the Double Up Food Box program, which we know that through BCTR and ARC, there's a huge evaluation going on in partnership with Phil and Fork. That's really exciting that this is happening in-house. And the concept is that this program incentivizes this SNAP spending on fruits and vegetables by matching each dollar spent on SNAP purchases up to $20 per day. So I'm using that as one example. The next level it's my fault. The next level is government nutrition security programs. You can think about this as SNAP and WIC. At this level, although there is quite energy, to prioritize nutrition security through these programs, historically they have adopted a food sufficiency model, and I think there's a lot of work going on to strengthen the public health impacts of these programs. These programs, as I said, include SNAP, CMPs, and some argue, at least my colleague Amy Yurok and others, argue that WIC is our first food as medicine program because of their provision of nutrition and health services in that way. Since the 1970s, WIC has provided nutritious foods for pregnant and postpartum individuals and children, along with a health assessment and nutrition education in a healthcare setting. WIC provides ongoing evidence that federally funded food as medicine type initiatives are effective in addressing diet-related health disparities. So I'm using WIC as the example here. The next level is product prescription programs or coupon voucher redemption programs. These programs are probably one of the most encompassing ones because they focus on both primary, they go from primary to tertiary prevention, from medical treatment or preventive service. There are specific eligibility criteria for those who will ultimately benefit from these programs. And the coupon or voucher concept of it, just as an example for you, Are prescriptions that are issued in the form, again, of coupons and vouchers that can be redeemed for pharmacies, farmers markets, mobile markets, DSA subscriptions for up to 6 months. That could vary depending on the program, but that's, for the most part, the structure. And they often have a component of a referral coming from a healthcare provider. Okay. The next level is medically tailored food groceries or food packages. These are more at the secondary and tertiary prevention levels, targeting patients with certain medical diagnosis and who are experiencing both diet-related chronic condition or food insecurity. And these packages looks like, as you would think, is either a box or a package of groceries, primarily those that are nutrient dense or include fresh produce, that with the assessment of a registered dietitian nutritionist can help meet a specific medical or nutritional need of the recipient of the program, and includes a home delivery component or another arrangement for up to 6 months. So again, I won't go into too much details here because I want to get to the bottom of the talk, but I want everybody to be on the same page about food as medicine programs. And then the last one is medically tailored meals, which we'll actually use as an example of where the evidence is in a little bit, but also is a secondary tertiary prevention level type program for patients with specific medical diagnosis. And this is meals that or a dietary plan recommended by a dietitian with a referral from a healthcare provider that helps address a medical condition, a symptom, allergies, a medication, or any other side effect or other types of outcomes. And there's some additional meal support provided to the entire household based on food insecurity screening. And we'll talk a little bit about some examples later. So overall, these are the categories in which you can begin to think about food as medicine interventions. I wanted to say a couple points before moving into the next part of the talk, is that in general, individual level food as medicine initiatives focus on increasing affordability of nutritious foods and or strengthening local health and social support systems. Whereas when we move more into the population level programs and policies, these focus on influencing the larger socioeconomic circumstances and population, environmental, and working conditions. However, we must acknowledge too that there is variation in food as medicine components, from intensity to level of support to counseling and education to the practitioner involvement, screening and referrals. And it is important to acknowledge this diversity and variability as we think of food as medicine as a promising intervention or innovation. Okay, so the next part of this talk is to talk about food as medicine prioritization. Currently, there is, oops, I'm in the wrong place. Sorry, I just need to, okay, so I'm in the right place. Food as medicine prioritization at this point have been elevated ever since the response from the Biden-Harris administration White House Conference on Hunger, Nutrition, and Health, and subsequently their national strategy. I am just putting a pin on a part of the document that talks about the importance of food as medicine as a way to provide greater access to nutrition services and access to nutritious foods ultimately. And ever since then, there have been substantial investments, both financially as well as I think informationally and in terms of prioritizing science in this space because of these large investments and interests. And so I'm just putting a few examples. I don't know if you all follow local news, but just last week we saw New York pass become the 8th state that in which the 1115 demonstration amendment is passed, and we can aid state to do so, which allows for insurance to be able to support services related to social determinants of health, from housing to other, food is another one. And it's particularly important for food as medicine interventions because these then become fundable through insurance. That's one other way. So again, the investment is large, the interest is large. We also are seeing that we have the upcoming 2024 Farm Bill, and as of the 2018 version, we had a $250 million investment in financial incentives for fruit and vegetable through the GUSNIP program. And there are a number of technical assistant evaluation centers to support food as medicine work that are also funded through the USDA. There's the GUSNIP Nutrition Incentive Program Training, Technical Assistance Evaluation Information Center, and NIH also started developing a concept for food as medicine networks or centers of excellence. So again, this is this part of the talk is really to help us put in perspective how large the investment has been towards food as medicine programs. But do we have enough food as medicine evidence to justify these large investment? And I think that's a question to be made. And sure, from a type 1 evidence perspective, we do know that the greater the density of nutrients is on certain foods, the better it is in terms of health outcomes. And we should be encouraged that although we don't have enough type 2 and type 3 evidence, we need to be working towards doing the best job we can to see how efficacious and effective these interventions can be. So let me just take a pause here, because I guess the point is that at this point, food as medicine is an intervention that can help us translate some of the type 1 evidence that we've gathered so far in the nutrition space. And type 2 and type 3 evidence is something we're working towards. And as it emerges, we should be, I think the argument that I'm trying to make with this presentation and in this manuscript is that we should be prioritizing both types of evidence in the implementation and evaluation of food as medicine initiatives. So where I'm going next is to make the argument for one way to think about generating type 3 evidence for food as medicine. But I did want to take a time to look at some of the type 2 evidence from one subset of food as medicine, which is specifically medically tailored meals for a specific audience, in order for us to get an idea of where we at with type 2 evidence, with the things that are coming out that are encouraging, but the things that we still need to get better at. So I'm gonna use 3 articles. And again, these are studies that specifically focus on one type of food as medicine intervention and are studies that focus on a comparable population in order for us to really compare apples to apples, so to speak. This is an evidence synthesis conducted by Gao and colleagues. Sorry, my notes are all over the place. So let's start with this one. So Gao and colleagues recently published a systematic review and meta-analytic data on the effect of food as medicine interventions broadly, including post-prescription, medically tailored groceries, and medically tailored meals. And in their assessment, about 16 studies met inclusion criteria, and participants were categorized either as low income or food insecure with prediabetes or diabetes. The primary outcomes of interest here were fruit and vegetable intake, as well as A1C levels. And for reference, we want A1C levels to be lower in general, and a reduction of 0.5% it equates to a clinically meaningful change. So in this study, there were about 5 to 8 studies that report a significant increase in fruit and vegetable intake, and about 7 out of 14 studies report a significant decrease in A1C levels. Beyond this qualitative synthesis, a meta-analysis of 5 RCTs in the overall 16 included studies, which included about 843 participants, resulted in a clinically meaningful reduction in A1C compared to the control group. The mean difference was about 0.47%. And again, that's something to note. Something else that I thought was interesting in this study is that the authors found that both medically tailored groceries and medically tailored meals were actually more effective in increasing fruit and vegetable intake compared to post-prescription programs. And so that's something to think about as we think about the different types of programs of what they can do. Now, while this can be considered a step in the right direction, with more studies emerging and we being able to do the kind of synthesis that they did, I think we need to think about some of the limitations. We know in this study, I reported here, there was about half of the studies included that had high risk of bias due to missingness, detection bias, or confounding. I also want to note that there was high heterogeneity across the studies that were included in the meta-analysis. So not one program is alike the other. And I think it's important to think about, why that is. And, does that give us, enough confidence to translate this evidence in a real world sense. So that's one example. I'm going to go to example 2. I'm going to use Berkowitz and colleagues' work, which they use a randomized crossover trial to test the effectiveness of an MTM medically tailored meal program on patients with diabetes in households with low income, and found that patients improved diet quality, food insecurity, and also had reduced hypoglycemia. There are a lot of things to be encouraged by with these findings. Number one, that diet quality was greater for those that were in the intervention portion of the program compared to those that were in the control portion of the program. And also that there were some secondary outcomes of interest that looked better for the intervention for participants in the intervention portion, from lower food insecurity to less hypoglycemia and less days where mental health interfere with quality of life. But again, and I wanted to say another point. In this trial, the researchers have also been able to demonstrate that the study had high satisfaction for those that participated in the program. The program also reduced stress, burden of diabetes management, and there were opportunities to improve the program. There were examples of ways to improve the program forward, which is exciting. But again, limitations worth noting, there was a lack of a control group here. And all the results are encouraging in terms of promoting diet quality. There's no evidence that it has an actual effect on health outcomes. So again, evidence is emerging, but it's still not enough for us to think about that translation piece. I'm going to use one last example, and I want to thank Dr. John Cawley, our own John Cawley, for sharing this paper, reaching out and sharing this paper with me. I had read it and I thought it would be worth adding to the discussion, since it's another study with a larger sample at a larger scale, published in a really strong journal, and it allows to again compare those apples to apples. But comparable target audience to the other studies presented. There were about 465 participants total in this intervention. And the intervention model is quite interesting. The participants received healthy groceries for 10 meals per week for an entire household during 12 months. So the intervention was for a period of 12 months. And unfortunately, here again, we see the limitation of the control group. But the control group were essentially receiving 6 months of usual care, and then they were able to participate in the program the remaining 6 months. So and you can look at the description of the intervention here. I wanted to say the primary outcomes here was A1C levels, again, at 6 months, really to compare, make that between group comparison of the intervention and the control groups. And from findings, I'm gonna jump right away into the findings. Both treatment and control groups experienced a substantial decline in HbA1c levels at 6 months, resulting in a non-significant between group adjusted mean difference of negative 0.10. Again, non-significant. So, another example of where the evidence might be here when it comes to how these programs influence health outcomes. There were some positive things, like this increased access to preventive health care, from more visits to dietitians for the intervention group, to active prescription drug orders, as well as self-reported improved diet. So some things to be encouraged by, but again, another example of note that type 2 evidence for food medicine is still emerging. So moving forward, I guess the point that we're trying to make, or I'm trying to make here, is that ensuring outcomes among all types of evidence should be a priority in food medicine initiatives. And as needed, hybrid studies might be helpful because it allows to look at both effectiveness as well as implementation. For the purposes of this talk, I want to primarily talk on the need for type 3 evidence, given that this lens has been lacking in current research and practice efforts related to food medicine. I also think that if we're going to have the conversation about health equity, an implementation science lenses, can help us get there. Okay, so why should we care about implementation and implementation research? I'm going to make 2 points here. I guess one, and then go in depth into it. On the right side, you see the image of the 17-year odyssey, which is how we, on average, translate evidence into daily routine practice. And what we know is that it takes between 15 to 20 years to translate evidence into practice. And those gaps, unfortunately, might be a reason why we see disparities and inequities related to chronic diseases. So in addition to the length of this knowledge translation from research to practice, in healthcare, what we know is that we consistently fail to translate evidence into practice, with 50% of patients not receiving recommended care, with 30% of medical spending redundantly spent in unnecessary care, and many populations not benefiting from research evidence. So this might be one contributor for the disparities we see in chronic disease outcomes. So implementation science is the systematic study of strategies to increase uptake of research findings. It could help us implement promising innovations, but it could also allow us to identify ineffective or harmful guidelines, practices, policies that may need to be implemented. The research context for this work is dynamic, it's complex. It happens in the real world where people live and work. And it has also been referred as the black box. And as some peers might be looking at the effect of an evidence-based intervention or empirically supported treatment in relation to a specific health outcome. There's a lot that happens in between that is often requires to be accounted for as well. And so these are the things that implementation research can help us do when we're trying to see whether an innovation has an effect on health outcomes. Want to make sure. Okay, so where do we start? This is TMF stands for theory, models, and frameworks. And in implementation science, we have a plethora of different types of frameworks that could be used to do this work. But unfortunately, it's really hard to make a decision on one. Here, sorry, and I want to draw on my notes. The application, again, it makes the application difficult when there's a plethora of TMFs available. And also, if we think about the diverse context where food is medicine specifically could be applied, it could be in a clinical setting, but it could also be in the community setting. It doesn't happen in one standard place. And in general, these frameworks offer flexibility and can be looked at across several socio-ecological levels. But depending on the scope of work, there's actually 5 different types of models, theories, or framework that you can choose from the process model to the determinant model to the classic theory, implementation theories, as well as evaluation frameworks. To aid in the selection of a framework for those unaccustomed to implementation science and without robust implementation research or practice support, we are using the exploration, preparation, implementation, and sustainment framework as a case study and a pragmatic option applied before in public health service as a case study. So that model specifically falls in the process model category to describe or guide the process of translating our research into practice. So here's the model, and I'm going to break it down for you, but it starts with 4 phases. It starts from exploration, which then goes into preparation. The third phase is implementation, and then the last phase is sustainment. And it's all cyclical. It's meant to inform one another. And there are 4 domains that could be examined across the 4 phases, from the bridging the outer context and the inner context, as well as the bridging factors and the innovation factors. EPIS was developed for applying innovations in health services settings, similar to food is medicine initiatives, and has ever since been used widely across multiple public health and policy disciplines and issues. There are 2 arguments to be made on why the choice of this for this case study. One is it offers the pragmatic lens because it's happening in the real world, because it's happening in health services implementation and other public health practices. It can be used in an applied way as well as in a research format. It's also a framework that has been used for understanding not just innovation implementation, but also policy implementation. And as we think about food is medicine and the large interest that policy groups have in propelling this type of innovation in the real world, it's a fitting model for thinking about this. So the innovation will be something like the design, the components, and the fit of fit initiatives. Food is medicine initiatives. So that's your innovation and all the components that it entails. The bridging factors might be the partnerships and actors charged with supporting the food is medicine innovations in the standard practice or in the context that is implemented. And then we have the outer inner context, which will vary from program to program, from policy to policy. But you can think about it. You can think about the inner context as your local setting, and the outer context as everything shaping the decisions happening in the local setting. Okay. So EPIS is, again, a framework used as an example here, but it's not a silver bullet, and it's not the only framework that can be used. So I want to drive that point that we're just using it to think about implementation as we also think about effectiveness research. Because we have opportunities to also do effectiveness in the context of implementation, it's good to pair them as we're continuing this work. But implementation research necessitates an equity lens. If implementation is inequitable, then disparities in chronic disease may increase. Sorry, I got ahead of myself. If one applies a set of theory, models, or frameworks, or methods, or interventions, and or measures designed for a general population to a vulnerable population, existing disparities may be maintained or widened. So we also in addition to the implementation aspect of this, we also cannot ignore structural drivers of inequality, namely racism, when designing and implementing programs because they may promote injustice. So to address these and other limitations in implementation research, there's some approaches that have been taken by implementation scientists, from building equity principles into existing TMFs, to developing new equity-centric theory models and frameworks, to aligning implementation with theoretical underpinnings of health disparities and equity research. In this study, one thing we did was to think about equity principles in the context of EPIS, and talk about what is the lens that we need to have as we're using EPIS to frame implementation work for Foodist medicine. I want to talk briefly about context and process, although I'll mention it later, but a lot of implementation work is also about understanding context and process for producing knowledge on how to design, adapt, sustain evidence-based innovations. And context and process include real-world events, things are happening right now, like our climate crisis, resources available, organizational and societal culture, power structures, collective actions, and others. So we need to think about this context and whether it's enabling as we are testing whether interventions are effective and implementations are effective for positive outcomes. And we also need to think about breaking down structural barriers. For instance, access to healthcare is not just meeting with your provider or going to the hospital. It also means that access to healthcare could be hindered by geographical distance, lack of transportation, employment requirements, confinement due to incarceration, refugee status, migration status. We also need to think about healthcare knowledge and whether it's affected by literacy levels, language barriers, cultural preferences, limited access to technology, so forth, so on. And so social determinants of health, again, is another way to think about all the different factors that could be implicated in healthcare access broadly, but as we think about Buddhist medicine interventions as well. Okay, so EPIS as a case study is on the left side, and some of the arguments for why we need to think about these four different constructs. One of our arguments is that if we apply the anti-racist, contextual, inclusive, and multi-sectorial lens, we will make a more equitable implementation of EPIS and, a more equitable implementation of Buddhist medicine innovations. And we're also able to test effectiveness concurrently with equitable implementation. And as such, there are four core principles that we propose in this work. First, that Buddhist medicine interventions are anti-racist, that they acknowledge that racism is a fundamental driver of health inequities, that a lot of this work is contextual and needs to account for the environmental, social, organizational, political context, and the variations across settings to disable potential harmful or unjust manifestations that could further exacerbate inequities. It needs to be inclusive and account for as many lived experiences and communities' voices in order to prioritize as many individuals as possible, and multi-sectorial. And the multi-sectorial piece, is just as described, but one thing that in this work we've been thinking a lot about is the medicalization of Buddhist medicine interventions. A lot happens in the clinical setting, a lot happens in the medical context, and we need to think about power structures and dynamics as we're doing some of this work, because there's a lot of other community sectors implicated in Buddhist medicine, not just medical and health sectors. So thinking about the multi-sectorial aspect of this type of work is also important. So there's at least four main points that were part of this presentation. And really all I want to do is have a discussion about what your thoughts are about where Buddhist medicine is and where it can go. But number one, rapid and significant prioritization and investments of Buddhist medicine is happening at a very large scale, with projections of permanent, long-term Buddhist medicine investments for both from both public and private sectors. As the Buddhist medicine evidence continues to be established, I think what this study is trying to do is, can we standardize the evidence base to maximize Buddhist medicine reach and impact while demonstrating return in substantial investment? We are using EPIS as a case study here and one pragmatic tool, but when we think about implementation science, we need to know that it's diverse and there's no framework that is a silver bullet for understanding implementation. This is just one idea and one way in which we could think about implementation as we continue to generate type 2 and type 3 evidence. And as highlighted in this presentation from the onset, we hope Buddhist medicine efforts can and should, we hope they are designed and implemented using equity-centered principles. With that, I leave you with my references, and I hope you have questions. Thank you so much for being here.
Thank you so much, Roger. Are there any questions in the audience?
Hi.
Well, it's just interesting to be eating lunch. It's wonderful to have lunch, but I'm just wondering about like white bread, barbecue chips, and a cookie that's like as big as your head, maybe like meant for 3 people. Like, how would you improve? I mean, it's so ingrained, like that this is what lunch is, you know, in culture. How would you improve this? Like maybe trade the cookie or a smaller cookie for a whole grain bread option or something like that? What would you recommend?
I don't know. Maybe the food services need to look at the dietary guidelines and they could align there. But I don't know. I mean, I don't know that the talk addressed that. So I feel like, but we can have that conversation after this. Yeah. Well, I think the point is that Buddhist medicine programs really, for the most part, are about promoting foods that are nutrient dense, particularly those that are produce and healthier options. So Shortstop Deli didn't sponsor this talk, by the way. I just want to make sure that you know that. But thank you for the question. I mean, yeah, I'll say just eat in moderation, maybe, if I can say that. Thank you. No, I'm good. I'll grab one at the end.
Hi, thank you.
It's a little low,
You-
but it's
Okay, all right,
I can hear you.
great. I know you can. I guess it's probably for the Zoom folks. My question is about the length of interventions. This is something I've been thinking about a lot as I design an intervention, and I've been heartened to see in the literature that even short interventions in around 2 months, even 3 months, you can get markers to move significantly, like hemoglobin A1C, C-reactive protein, heart disease markers. And I'm interested in that in relation to how it relates to Alzheimer's disease. But when I think about what's going to be good for the people who participate in my intervention, I think it's not unreasonable to suspect that you could have an intervention that's short but leaves a lasting impact. But then you could also have something that's short and then everything goes back to the way it was when you leave. And I'm wondering if you have any knowledge on how people think about that. What kind of things leave a lasting mark and are worth it for the participants in the long term, not just as a data gathering tool?
Yeah, that's a great question. And I think, what we're seeing is that what would happen without these programs? They come and then they go, what, like you say, I think these programs need to be sustained in some form or way. And whether it's that the intervention continues or it's sort of more of a sustained program or service, or there's supplemental components to it.
They're like skill building.
I don't know. I think that's a great question. I do know that in a lot of the concepts that are out for the encouragement for Buddhist medicine intervention development, there's a lot about nutrition education and counseling that is still not well fleshed out, although are complementary parts of Buddhist medicine, but could be what allows us to think about that skill building piece. But I don't know that is currently, the main components of Buddhist medicine interventions right now. But without them, yeah, what happens after? I don't know. I mean, I guess, if we go back to the earlier part of the presentation where most of these programs aim to improve affordability of and access of these types of foods. Maybe we just need to make the nutritious food more affordable and accessible to as many people as possible. And then, skill build from there. But that should take precedent. Mm-hmm.
Hey, Roger.
Hey,
Nice
Laura.
job. So you and I have had this conversation, but I'm hoping you can comment here for the group in the sense that our field of nutrition is moving with food as medicine is the hot topic and way to go. But it has a very strong focus on food and nutrient, and it's missing the social aspect of food. And we know that in disease prevention, especially with elderly, eating with people and having the social aspect that goes along with mealtime can be a really strong predictor of quality of life and disease prevention itself. And in early childhood, we know that role modeling and all these other social contexts. So as our field is moving to this food as medicine, and I'm not arguing with what food as medicine is, but how do we enhance it that we don't miss the social aspects of food? And it becomes, again, we go back in time to the only thing that matters with food is the nutrients and not the big context.
That's an excellent question. And I think where I immediately go is also, are these programs solely meant to influence individual level health outcomes? Do they have other benefits as we are developing and implementing them for our communities, for the providers, for those that produce food? Can we is food as medicine exclusive to nutrition and public health and medicine? And I think if we think about them as much more than just help promoting interventions, I think we can get into the social pieces. Yeah, I mean, just to draw on one example from one of the studies shared, but that some of these medically tailored meals reach the household. It's an opportunity to look at family dynamics and meal times and things of that nature. And I don't think we're doing that. All we care is, are these effective? Right now, we're working on, are these effective? Do they translate to the real world? And but I do think that we need to also look at those outcomes. So thank you, Laura.
Thank you so much, Roger. We have a couple questions from the chat, but I'll start with the first one. From our colleague Jamila Simon, I love the acronym FAM, food as medicine versus food in medicine, but how do community members carve out space to ensure Black farmers, smaller producers are part of the conversation and contributing to the solutions to help community members engage in utilizing FAM?
I actually, Ibugun is here, but I would use FAM a lot, and then they told me the convention in the field is to use FIM, so I went with FIM because of the convention. So thank you, Jamila. I will say that's a great point, and we're actually thinking a lot about that in our own work in the lab, especially because it is BIPOC and underrepresented or farmers with underrepresented or marginalized identities that often do the work of growing, our produce at a small scale, in challenging circumstances. And I'm not going to go further than that, but I have to say, I'm going to cite Darius Mustafarian here because I think in one of his recent talks, he talked about the role of agriculture in food as medicine. And I don't think, and also the role of thinking about sustainability and sustainable diets as we think about food as medicine. And I think that speaking strictly about food as medicine, I don't know that we are as intentional about that equity piece when it comes to developing, designing, and implementing these programs. But we should. And I think, again, for me, I think what the homework is that we can try to look at some of these equity principles to try to close that gap a little bit and make these efforts a bit more equitable if we're able. So thank you.
I'm sorry, I can't resist also talking a little more because I'm going to do some promotion for Roger that I don't think he'd do for himself. So one of the things that Roger and I in the Fig Lab participated in a lot last year was the Food as Medicine Coalition for the state of New York, and the steering committee putting together the recommendations for how the Medicaid 1115 waiver should pay for food as medicine initiatives in our state. And one of the focuses of that was writing a small research brief on making sure participant voices were informing the process. And then the other part that we were working on in the fall was we submitted a policy brief to the Department of Agriculture and Markets and the governor's office, showing that including some kind of Buy New York requirement within the Medicaid process and combining that with New York procurement law, which prioritizes 30% from minority and women-owned businesses. By doing that, you could assure that the Medicaid dollars were not only feeding people, but were also circulating through the agricultural economy of New York. So there is, especially with the Medicaid food as medicine programs, because there's a regulatory aspect to it, there's an ability to do that on a large scale, whereas some of the sort of private and grant funded ones, it'll be ad hoc as to whether people prioritize it.
I also brought the notes from our last New York State Coalition meeting. There's actually, after the 1115 approval came last week for New York State, in the recent, there were the top 5 ranked priorities for the coalition. And at least 2 of them, I think, are pertinent for this work. One is the social care network and clinician food as medicine advocacy, education, and standardization. I think that's an opportunity to think about, bringing those concepts forward. And then the most important one, I think, is thinking about food sovereignty, local food systems, and BIPOC producers in this work here in New York. So I think there is, we're not there yet, but it's part of the conversation, at least as it pertains to local and state affairs.
I hope you can all hear me. I came in late, but I have been watching on Zoom, and I was wondering, with this food as medicine initiative, does it include a way that when we talk about health equity, and I think cross-cultural communication becomes really important, does it include a way to kind of guide families or patients, whoever is using this program, to know how to incorporate these different nutrients into their meals? Because I think different households are very different and use different nutrients very differently. And so for me, I know I just got started into learning how to incorporate certain vegetables and fruits into my meals. And it was hard to do that because you think that it's easy and you just go and you buy it, but then it's another thing actually using it. And how do I use it in the most healthy way? Mm-hmm. So does this program have part of its initiative as like, we're going to guide you and show you how to incorporate these nutrients into your meals?
I think for the most part, they're very standard. I think from context to context, they might have some variation and tailoring to the population that it might be serving. I do think there is an interest, well, not an interest, but I'll say one reason for also thinking about implementation is that if these programs are meant to be available for all, they need to account a priori for the particular needs and preferences of the population that they will intend to serve, and that could include, cuisine of interest and things like that. But I have to say, for the most part, what I've seen is there's a predominant of food is medicine approach that is almost standard. That there's, and so the tailoring is very context specific. As it should, right? Because even if we have various models in large parts of the country, they will look different depending on who they might be serving. So we definitely want the tailoring. We definitely want the context specific, but it needs to be done sooner than later. And I think the nutrition and counseling comment also comes into play. There might be a way to use that as a complementary form for the intervention in that sense.
Thank you so much. This is the end of our talk